The Autism Research Institute relies on the generosity of donors like you to make this webcast possible. If you enjoy this presentation, please consider making a donation. Thank you.
Dr. Carla Mazefsky is a licensed clinical psychologist specializing in autism spectrum disorders and an associate professor of psychiatry at the University of Pittsburgh School of Medicine. Dr. Mazefsky was the 2012 recipient of the Ritvo-Slivka Award for Innovation in Autism Research. She is associate editor of the Journal of Autism and Developmental Disorders and is a former member of the board of directors of the Western Pennsylvania chapter of Autism Speaks. Her research is focused on emotional dysregulation in autism, including the identification of underlying neural mechanisms, the conceptualization, treatment, and assessment of problems with emotional control, and co-occurring depression and anxiety. These webinars are made possible through generous donor support, including a generous grant from Local 25 Boston Teamsters. If you'd like to contribute, please visit our website at autism.com. And now I will turn this over to Dr. Mazefsky.
All right, thank you very much. So I'm going to talk about emotion regulation in autism today. And I also want to apologize, the camera angle on my computer is a little bit funny, so it won't look like I'm looking straight at you. I apologize for that. Okay. Oops. All right, so it was difficult to decide what exactly to cover, knowing there's probably a mixture of parents and professionals listening in. So I thought I would start by just sort of emphasizing why I care so much about emotion regulation, which is really what I've devoted my career to, why I think it's so important to ASD, and how we can think about supporting individuals with ASD who struggle in this area, both in terms of what the current best practices are, some general tips, and then I wanted to highlight some of the research that we're doing to move the field forward. So first, I just want to talk about where emotion regulation fits in within autism. Obviously, autism is diagnosed based on social interaction, communication deficits, and repetitive behaviors. But as anyone who works with or lives with people with autism knows, it's much more than that and can affect all different parts of the body and daily living. So this is a slide from Autism Speaks that illustrates that fact. You won't see emotion regulation listed on there. And I think that's because really people have emphasized the comorbid disorders and associated features, and it's only been recently that emotion regulation has gotten more attention as a possible mechanism underlying all of these co-occurring concerns. So we did this paper back in 2013, and at that time there are only 15 articles written focused on emotion regulation in autism, which was in stark contrast to the number of books and resources available on meltdowns, which was a common parent concern. And fortunately, you know, since we have raised this issue, there's now much more research. In 5 years, it's jumped to 117 articles on the topic. So that's to say we're just sort of starting to get into this area, and we are learning a lot more, but it's still kind of in its infancy in terms of our understanding of emotion regulation in autism. So when I say emotion regulation, what exactly do I mean? These are two of the common definitions of emotion regulation in the field in general outside of autism. And the things I would like to emphasize are that it's really about handling, modifying, changing emotional reactions in terms of the intensity and duration of the emotion, all towards being able to have a more adaptive and appropriate response to achieve your goals. And the other thing I want to point out is that my emphasis is on not just how we change or modify the emotional reaction, but also that initial experience and expression of it. So I think it's important also to consider like how strong is the initial reaction, how fast is the initial reaction, in addition to how we can modify the reaction once the emotion's being experienced. And emotion regulation can be considered something that you are really aware that you're doing, like a voluntary or effortful control, or it can happen really what we consider implicit, like without your own awareness that you're doing it. Okay. So that's a formal definition. In reality, I think when emotion regulation doesn't work well or goes wrong, it can show up in a lot of different ways. So sometimes what we see are the behaviors. So all of these are examples of ways in which we may observe problems with emotion regulation. So repetitive behaviors, aggression, self-injury, increased withdrawal, general deterioration, meltdowns, outbursts, explosive behavior, crying, sadness, anxiety, and then anger and irritability. And any of these can be transient or more sort of chronic and persistent. I want to point out too, this is just to give a framework how I really think about emotion regulation and measuring it in my studies, is how these items are defined here on these emotion dysregulation inventory reactivity short form. So one of the reasons that we don't have a lot of research on emotion regulation in autism is in part because we have not had great measures that work in this population. Most of the measures of psychiatric symptoms, emotional problems have been developed for other populations and excluded kids with autism when they were validating them. So we don't really know if they work the same way, if they capture the full range. And then in particular, they don't work well for kids who are nonverbal or minimally verbal, because most of the questions that focus on emotion regulation or emotional concepts in general have items like complains about, worries about, or ask questions that would be really hard for someone to answer about someone who's not able to convey their thoughts and feelings verbally. So we developed this emotion dysregulation inventory, and I'm not going to really talk about it too much today because that could be a whole hour talk in itself. But we are excited that it's a new opportunity to begin to really understand these processes across the autism spectrum, because we developed it to be useful for autism with any verbal ability. And our methods sort of showed that it does work regardless of the child's or adult's verbal ability, IQ, age, or gender. And these 7 items that are to the left are some of the key items from the form, and so how we think about when emotion regulation has gone wrong. Okay. So another critical distinction that I'd like to make, so if you remember one point from this talk, I would maybe suggest remembering this one. We're not talking here about temper tantrums. So temper tantrums are different. That's when a child or adult doesn't get what they want and they have this reaction, and it's a very goal-directed behavior. They're trying to get that thing that they were told they couldn't have. And this is not to say that people with autism don't have temper tantrums. Everyone occasionally can have a tantrum of some kind. But what we're really talking about, I think, is very different. It's more of the meltdowns, the agitation. It's not a manipulative behavior. It's not goal-directed. It's really when emotions are stronger than the skills that they have to regulate them, where they become out of control or interfering. People have called it extreme emotional behavioral response to stress or overstimulation, a catastrophic reaction. So this is very different because it's really stemming from an underlying skill deficit, a sense of being overwhelmed. It's not something purposeful. Okay, so I just want to briefly discuss why we think this might be such a major concern in autism. I think there are reasons to believe that people with autism might be at increased risk for emotion regulation difficulties. One line of reasoning is we know that from family history studies that parents of kids with autism are more likely to have mood disorders, and this is often present before the birth of their first child with autism. We also know that From the non-ASD literature, there's a body of research pointing to which neural structures are implicated in emotion regulation. And although emotion regulation has not been studied from a neuroscience perspective much in autism explicitly, we do know that those areas vary in the function, size, or circuitry with other parts of the brain in autism. So we know that they're affected, which would likely lead to difficulties in this area. And then also, emotional differences are often present very early in autism, sometimes even before we can pick up on the social and communication deficits. So there's literature from, and these are just two examples, but there's literature from the infant sibling studies that study the younger infant sibling of a child with autism. And they have found that the kids who go on to have autism have more intense and frequent distress reactions as babies. They tend to be more irritable and have less positive emotion. So all of this is already going on very early. And then when you think about autism, I think you can think about all the different things that are affected for people with autism and how they could play a role in increasing risk for emotion dysregulation. So I'll just go through a couple of these examples, but we know that many people with autism have poor flexibility and cognitive rigidity, and that could be something that in a situation that could lead to increased emotional distress and then difficulty downregulating that emotion. We know that there are sensory sensitivities, and that's another thing that could lead to increased stress and difficulty appropriately regulating that arousal. So you can kind of think about all of those different things that may play a role in increasing risk for autism that are related to characteristics that we use to define autism itself. This is just another way of saying that, and just in interest of time, I'll pretty much skip over this. But the idea is that you could think about, again, all of these areas that we think of as core to autism itself, and really any one of them could be considered a trigger for poor emotional control or difficulty with emotions. So there has been a growing body of research on emotion regulation in autism, and I would say these are some of the main conclusions that we would have at this point. Again, this has mostly been research on verbal, more cognitively able populations, but that research does suggest that people with autism tend to rely on the less adaptive, the less goal-directed strategies, so things like suppression of emotion, shutting down, things that tend to be less effective in regulating emotion. There's been somewhat inconsistent research on the use of more helpful strategies, like being able to think about things differently, which is called cognitive reappraisal. Some studies have shown that people with autism report using those strategies as much as typically developing peers. But then I think the issue might be that we've also seen that even when they do use those strategies, that it tends to be less effective than their non-ASD peers. And this is just to quickly highlight, there have only really been 2 studies of the neural basis of emotion regulation in autism. And this is just showing what they found was poor connection between the frontal cortex and the amygdala, which is considered basically a loop that's very involved in emotion regulation outside of ASD, and you see similar patterns in ASD. So that was sort of a rapid fire overview of what emotion regulation is in how we're thinking about it in autism. And I just wanted to next highlight why I think we really need to pay more attention to this area. So the research also shows if emotion regulation is impaired, the more impaired it is, then the more anxiety and depressive symptoms you see. And again, this is all research in autism. More externalizing behavior, so more aggression, worse social functioning, more difficulty in mainstream classrooms, difficulty with the college transition, and more likely to require psychiatric hospitalization. We also did a study This was in partnership with the Interactive Autism Network with 1,228 parents of kids with autism reporting on their child's emotion regulation with our new measure. And we asked about history of services. And basically what this figure is showing you is that we found that kids with higher emotion dysregulation were much more likely to have all of these problems that you see here, to get suspended from school, to have school contact for behavior, to be in individual therapy, to require in-home crisis evaluations, to have contact with the police, and emergency room visits for behavioral crisis. So I think this is a real eye-opener, because this was not, what was most striking to me is that emotion dysregulation predicted all of these outcomes, but autism symptom severity did not. So it's really the emotion dysregulation that often is the driving force behind the need for these intensive and crisis intervention services. So I really think it stresses how important this is to think about in our treatment of autism. Okay, so how can we help? It was hard to figure out what exactly to put into this part of the talk. So I decided to focus on, what are the evidence-based approaches we can use now, give you some basic tips that I think are, key points to keep in mind. And then I wanted to focus also on highlighting where we're going in this area, and how I think we can improve on what are the current best practices. But really, probably the best option at this point is cognitive behavioral therapy. Now this is something that's most appropriate for verbal or cognitively able individuals, but it's an approach that's widely used outside autism, and it is probably the most commonly used psychotherapeutic, so non-medication treatment, also used in autism. And basically, it's referred to as CBT. CBT focuses on the connection between emotions and thoughts. So it tries to improve emotion regulation capacity by changing the maladaptive attitudes and thoughts to reduce overall negative emotion. It uses things like problem solving also, and exposure. So this is just one example of a concept that would be part of a CBT therapy. So the idea behind CBT is that often there are these cognitive distortions, which we sometimes call thinking traps, to simplify. But basically, the bottom is an example of that, where you wave at someone, she doesn't wave back, so you think to yourself, she must hate me, and that leads to anger and resentment, and that leads to the negative behavior of rude yelling. Whereas if you thought about it differently, as if she probably didn't see me, then you might feel disappointed but still determined, and then act differently in terms of, here the example would be cheerfully waving and trying again. So in CBT, you would work to identify what those maladaptive thoughts are and change those processes, with the idea that you can then modify this cycle and have less of the negative outcome. So it is exciting because research in autism in this area is in its infancy, but there's now enough research with randomized controlled trials that CBT is considered evidence-based for ASD. These findings are strongest for parent report over self-report, but the effect sizes tend to be large. They're a little lower than non-ASD populations, but still effective. I think what's really important to point out, though, is that most of this research, with very few exceptions, has been focused explicitly on anxiety, using anxiety-focused protocols. So it's a little bit less clear how well this would work for a kid who's just having a lot of meltdowns, but it's not anxiety, or who's severely depressed or irritable. But I think it's a good starting point. And the other nice thing about CBT is that there are a lot of therapists that know CBT, even if they're not autism focused. So We do know that there are some modifications that are helpful for youth with ASD or adults with ASD in terms of benefiting from CBT, but it is something that I think you could work with a therapist without particular expertise in this area who at least knows the strategies. And I know that therapists with specific expertise are not always available. So some of the modifications that are considered helpful for CBT and autism are more parent involvement, a greater focus on recognition of emotion, incorporating a predictable routine and structure into the therapy, of course, focusing on strengths and talents, and that could include pulling in special interests, more repetition than typical, and more practice, and then making the concepts more concrete and visual. So that could be done with multiple choice lists, using drawing or photography or whatever they might like in that domain, video examples like watching videos, making videos, written worksheets, and visual aids. So I am very encouraged about the state of the research on CBT and autism. I don't think we're done and can just stop and think we've figured this problem out. Aside from the fact that obviously that's not a solution for everyone in the autism spectrum, there are lower response rates to CBT in ASD. And then some of the research shows in kids, again, who are enrolled in studies for anxiety, who may have other problems, that sometimes those other problems don't respond as much as the anxiety. So you might see anxiety go down, but if they have non-suicidal self-injury or other complicating problems, that those might still persist even after the CBT. The other thing that I think is tricky about this model is that the protocols have been developed for specific disorders, again, mostly anxiety. But I think we know that most with autism present with multiple concerns. So it might not be just anxiety, it might be anxiety and depression, or it might be a kind of mixture of things, or have some behavioral issues. So it's difficult to have like just one intervention for each component. And then one of the things I think we really need to think about is that CBT is very what we call top-down focus. So you kind of need to be aware of the situation, when you're going to use these strategies, and it can be very hard to apply in real life, and I think especially once you're really distressed. So once someone becomes distressed, and I think often in ASD we see that that happens really rapidly, then it's hard to use these very, very cognitive strategies in that state. And I'm particularly interested in adolescence, and I think you see even more difficulty with this at that age range, in part, I think, due to hormonal changes. But so this is something that we've been considering in our research. And this is just sort of one example of how I think that process can be tricky in autism. This is, so if you remember the slide I showed with the thinking traps and waving hello, that's a good example if you can really easily pinpoint the thought that's going on. But often I think what we see, or what people with autism say they experience, is that, you know, something happens and they either have this sort of evaluation of it as, you know, not too noteworthy, or it's this sort of threatening or very noteworthy event that just sort of leads right to the emotion without that intermediate step of thoughts being noticed anyway. So that makes, you know, that approach a little bit tricky to apply. So for all of those reasons, we've been really considering mindfulness in our research. So mindfulness, you might have heard, because it's gaining a lot of popularity across all kinds of populations and even just school-wide programs. But it's the idea of attending to present moments and thoughts and emotions without judgment. So being mindfully aware of what's going on around you. And there are a lot of reasons that mindfulness makes sense to consider in autism. So it really focuses on awareness, and I think one of the major difficulties in a lot of these intervention strategies we might try is that there is many, not all, but many people with autism really struggle with awareness of emotions, especially at the early levels. So they might notice it when they're at a 10, but not really notice it when they're at a 2 and 3 and it's beginning to escalate, which makes it difficult to employ, regulatory strategies. Mindfulness can also be helpful with promoting the ability to slow down before acting. And because we see that one of the strategies that people with autism use that's not that effective is escaping and suppressing, we think that mindfulness can really help with that, because it's actually teaching kind of the opposite idea of like being able to notice your emotion and sit with that feeling. So we've been doing a lot of work over the past 2 years. We developed this treatment program called the Emotion Awareness and Skills Enhancement, or EASE program. This is together with my colleague or collaborator at Virginia Tech, Susan White. And basically, what we're trying to do is we're focusing on awareness of emotion, we're using mindfulness, and we're teaching distress tolerance. So unlike a lot of the CBT programs where the goal is really to reduce negative affect, we sort of are emphasizing that you cannot go through life without experiencing negative emotion. It's a part of life, and you will experience that, and it's not always a bad thing. But it can become bad when it becomes out of control. So we're teaching distress tolerance and then some strategies to handle emotions. So our goal is then, we're really targeting improved emotion regulation across the board. So we're not focusing just on anxiety or just on a particular comorbid condition. Our goal is to improve emotion regulation, and then we hope that that will then decrease a range of psychiatric symptoms such as depression, anxiety, reduce problem behaviors, and then improve overall functioning across settings. So I think I went over this already. This is just a different slide, but really what we're trying to do is target that underlying mechanism, which we believe really leads to that range of problem behaviors. So we're really trying to target the emotion regulation in order to improve irritability, anxiety, depression, aggression, and self-injury. And this is just an example of the model that we're using, and it's really driven by our conceptualization that individuals with ASD may react intensely to the emotion, and then it's difficult for them because of poor emotional insight and self-monitoring to use some of these emotion regulation strategies. So the entire program is really founded on the fact that increasing awareness is the #1 step. So we spend quite a lot of time increasing awareness through mindfulness, and then we work on teaching simple strategies to regulate emotion. And we use this ABCD model just as a simple coin to remember with this visual. And I did not include our pilot data on here, although we're writing up our data from our first open trial with 20, and we're now starting a randomized controlled trial, but could potentially talk about that more in the future. But we did observe really positive, very promising changes in depression, anxiety, problem behavior, and decreases in emotion dysregulation from pre to post on both parent and self-report in an independent rater. So we are very encouraged that this seems to be working. The families and participants really liked the mindfulness. Oh, I forgot to say we did this with adolescents, but we're doing it with adolescents and adults now. So I think this is sort of one direction where treatment of emotion regulation may go in the future. The other really main point that I wanted to emphasize in this talk, so this would be sort of point 2 if you remember one other thing from this talk, is that it's not about just that moment of losing control or the major meltdown. This is a slide by my good close collaborator, Matt Siegel at the Maine Medical Center. that sort of, I think, displays well the timeline that you could see and when you might intervene in different ways. So I think there's a point along all of this process when we want to think about supporting emotion regulation. So the very first thing is to pay attention to those early signs of distress. And this varies dramatically from person to person, so it has a lot to do with knowing the person who you're working with or living with. But these are some examples of strategies, of ways in which emotional distress may show up. So whining, rocking, oops, I'm losing my pointer here. Uh-oh. Okay, there we go. Clenching fists or tensing the body, pacing, saying no. Not answering, I think, is something to be pretty aware of because it's very common and often can be something that you see before a meltdown or as someone's getting more agitated, being unable to attain their attention. And the other big one that I think people don't always think of is we do see increased escape and avoidance behaviors, and including like extra silliness. So sometimes as people are becoming more upset and agitated, distressed, you see this hyperactivity or silliness. Okay, so that's sort of the early warning signs of that timeline. And so that's a point when, if you notice those things, you want to do your best to divert. Now, again, this isn't directly teaching the person skills, but this is sort of one way to support emotion regulation. So some ways that you can divert are to offer them to take a minute. This is not forcing them to take space or telling them to go to timeout, but this is providing a chance to take a break. If you're working on something that's not a critical behavior, let it go at that moment that you're noticing the problem, or that you're noticing early signs of distress. And this is not to say to like just not ever place demands on someone with autism, because that would not be a good thing to do for their overall development. But certainly when you notice this distress, you don't need to be pushing on something that's not essential to be working on in that moment. Removing the stimulus if there's something you can identify that's really clearly triggering, redirecting to the next thing with a visual schedule. And I can't stress enough how much that actually is effective. Also with emotion regulation, we're doing a study on an inpatient unit, and we do structured emotion tasks to try and understand some of the mechanisms underlying emotion dysregulation. So to do that, we do some frustrating activities. And we use a visual schedule, and often just pointing out when the next activity is very, kids are then able to self-regulate. They focus on that they can move on to the next thing. Using a visual prompt, like a first then card, offering a sensory option, or simplifying the task if you can break what you're doing down if you see early signs of frustration. There are things that are easy to do by accident that can inadvertently make the situation worse. So I just wanted to highlight some of those things to avoid. One is asking a lot of questions. Asking how someone's feeling. I think this can be a very natural thing that we would do with a friend who appears to be getting upset. But if someone has difficulty identifying their own emotions or isn't really aware of their feelings, this can be actually adding to their stress. Another thing that people with autism actually say all the time really bothers them, and I can very much understand why, is that it's very frustrating when they're becoming upset and someone tells them to calm down. I think most people would say they would calm down if they could, and they're experienced that overwhelming stress that I mentioned on that early slide about meltdown. So it's not really helpful in that situation to tell them to calm down. So to avoid sort of that phrase, if you can. Demanding eye contact, it's usually not a time to do it when someone is distressed because it can increase distress. Talking a child out of a routine, it may be that part of your treatment is working on decreasing and interfering repetitive behavior or something, but often it can be something that the child is doing to give themselves a sense of control over what's going on. Often the routine or repetitive behavior can be calming. So it's not necessarily a time to work on that treatment target if you're noticing increased distress. Trying to get in a debate about something also wouldn't advise. And then again, just asking to do anything except the essentials. So if you're noticing those signs, there are things you can do to support. And the number one thing is to remain calm yourself. Using the child's name when you're talking, simple statements. You can validate their emotion. So instead of saying, "How are you feeling?" you could say, "I can see that you seem mad," or "I could tell that you're upset. How can I help you?" So label it for them. And again, having this collaborative attitude of working on a problem together. And then I think the probably most important thing to do, and just remind yourself, because it can be very difficult in a situation that's escalating, is to remind yourself that the child is doing the best they can with the tools that they currently have. And that will help you support them if you keep that sort of as your framework. I wanted to highlight some other advice taken from my colleagues who work on inpatient units, which are to pay attention to your tone of voice, reduce the number of words you're using visuals to demonstrate the behaviors that are being asked, allowing extra time to process before repeating a direction or expecting a response, and being aware of personal space, because sometimes that, if getting in too close, can be perceived as threatening, or particularly if someone's already becoming overwhelmed, it can add to their sort of sensory overload. So the other thing to keep in mind is that, say someone's really upset, has a meltdown or some other incident, and it's over. It's not necessarily immediately over for that individual. And I think this is where we often see a lot of problems, time and time again, where outwardly the child or adult will look like they're doing fine, you think you've gotten past it, reintroduce asking them to do things, go back to what you were doing, and then it happens again. So I think what's really just important to keep in mind is that they may still be processing the event, they may still be agitated even though they've managed to calm down. So it's very important to remember that the child might not be back to their baseline or back to feeling calm immediately after experiencing a strong emotion or having a behavioral incident. So in that time period, I mean, often when things go really wrong with a big emotional meltdown or a behavioral reaction, the child, it may be against or might have an impact on the people they care about the most, and it can be a time, particularly for those who are really cognitively able, where they feel a lot of guilt and additional stress. So it's definitely a time to let them save face and appreciate that they weren't necessarily doing it purposefully, and acknowledge that it was hard. What can we do to make this easier next time? Things like that. Let some time pass. You can go back to those initial options that I mentioned before as diversion options and offer those things slowly to ease back into what you were doing. And it's also not a time to talk about consequences, like you just lost points or whatever system you're using that might be your behavioral strategy. Again, because they're still probably processing and still probably not fully at their baseline. Whoops, oh geez. Okay, so I was talking a lot about the timeline, and I think to me that's one of the directions we really need to go in, is to better understand if we can identify these early warning signs and also the period of recovery so that we can be more effective in our behavioral interventions. So I shouldn't have gone through that slide so quick. So we're doing some work. I'm part of a 6-site, recently 5-site consortium of research sites at psychiatric inpatient units that focus on kids with autism and developmental disabilities. And one of the things that we've been focused on is this idea of the underlying timeline and distress, and if we can pick up on that better. Because sometimes, I mentioned those early warning signs, sometimes it's obvious and sometimes it's not obvious. It's more difficult because oftentimes the person with ASD may not be aware themselves that they're becoming upset. So we've been focusing on initially looking at this with aggression, which is a common endpoint of severe emotion dysregulation, with this kind of model in mind, thinking that looking or considering that we see the problem behavior as an attempt to alleviate that distress. So they're feeling off, their arousal is off, they're not good at regulating themselves, and then it leads to this negative outcome, the meltdown or the aggression. What we've been doing to try and see if we can uncover that process is we've been having the child, the inpatient with autism, wear basically a wrist-worn device that collects physiological activity while we have a research assistant coding their behavior, onset and offset, that's time synced to the physiological data. And then our colleagues at Northeastern University are analyzing all this data to see if they can identify patterns that precede the aggression in terms of their change in arousal. And I'm not going to go through the nitty-gritties of this because it's a little technical, but the bottom line is the right graph is showing how often we could correctly predict the onset of aggression based on the preceding physiological data. And with just 20 minimally verbal inpatients, we've gotten enough data to be able to predict accurately up to 1 minute ahead based on 3 minutes of prior physiological data. So basically, from their prior physio arousal changes, we can see that aggression is coming. So what we really want to do is put that into a mobile alert application so that the child with ASD would be wearing the physio monitor, and it would be giving information on the status to someone who's working with them, and that could give them much more information on when to intervene, when to do some of those diversion strategies I was talking about, or, you know, I didn't get a chance to talk about all of the many other behavioral support strategies that there are out there to increase the time, basically, that we can respond. And the hope is that that could be done for that staff or parents could use that information, and even individuals with ASD themselves, in order to increase their own self-awareness and ability to use regulation strategies. And my real hope is that then you could integrate it into something like our EASE program to help with that part about awareness. So that seemed like a very rapid fire overview. For more information, you're welcome to email me. My website is listed there. If anyone's in the Pittsburgh area, we are currently enrolling for our treatment trial 12 to 21-year-olds with IQs of 80 and above. And then we are actively trying to get more funding for the physio mobile alert kind of project, if you know anyone who might have an interest in helping that effort. But at that point, I think I will leave it for questions.
All right, thank you so much for the presentation. We have a lot of questions today.
Okay.
One of the first questions we had was about the connection with parents and their loved ones on the spectrum, that interaction that goes on. You had mentioned that there's been some research on phenotype, that some parents have some emotional differences. So what, for parents who are contending in these situations and maybe experiencing their own stresses, has there been research on that, and are there any sort of collective treatment recommendations that have been made?
Yeah, I mean, I think for any parent of a special needs kid or any kid, I mean, it's very important to take care of your own mental health, because a lot of, particularly, I mean, being able to remain calm and supportive is hard to do when you're struggling yourself. I mean, I would recommend, the regular treatments that we know work for, difficulties with stress management, anxiety, depression in general, like psychotherapy. In terms of particular strategies that might be helpful, there is actually some research, it's pretty new, but there's some research using those same mindfulness strategies that we talked about for parents of kids with autism. And I think that's really promising and a great lead to look into. And now there's actually, if you don't want to go into the mental health side of things, I mean, there's mindfulness workshops. I mean, it's sometimes part of yoga, or just offered in like community settings. And it can be a very effective way to begin to work on your own emotional management. And in our EASE program, we actually do teach the mindfulness exercises to the parents also.
Okay, so that's a component of that program. And a lot of people asked about access to both the EASE program and then also the inventory that you described. So if they're looking if they wanted to get a hold of the emotional dysregulation inventory or learn more about getting the EASE program, how would they do that?
They could email me at that address. For the inventory, we designed that to be used. The goal was for it to be used to monitor progress in treatment, and would absolutely love for people to use it for that purpose, and also for identifying concerns. And are happy to make that available. I cannot share the EASE manual, as we're still actively testing it in the randomized controlled trial, but like if a therapist or a parent wanted to talk to me more about, what's involved in it, and, I could give some more background on what we do, I'm happy to do that. Again, just to email me would be the best way.
Okay, and for everybody, the email is there on the screen, and this will also be in the playback later. So if you need to come back and look it up, it'll be in the playback when the slides are posted online with the talk at ariconference.com. We have, again, there are lots of questions. One parent is asking, what's the difference between CBT and ABA? So what's different about those two methodologies, and how do you distinguish between providers who can provide that type of support?
Okay. That's a really good question. So they are pretty different, but they share an emphasis on the behavioral side. So they came sort of from different schools of thought, where the ABA is more focused on, modifying the behavior using different reinforcement strategies, and really focused on the behavioral side. And the people who are probably the best at doing ABA, BCBA degrees and backgrounds, although a lot of people can be trained to do ABA quite well even without a BCBA background. Whereas CBT is more along the lines of traditional psychotherapy. It's a very common part of most clinical psychology training programs, and there, a clinical psychologist would be the best person to offer that treatment, although some social workers and other fields also would have CBT training. And the primary difference is CBT is really focused on the cognitions or the thoughts, whereas that's less of an emphasis on ABA. They do have overlap, but they're usually used for different targets, treatment targets. But I would say the primary distinction is that emphasis on cognition, and it's just tend to have been used more on anxiety, depression, focusing on those sort of disorders we think of as psychiatric disorders. And ABA has been used obviously to teach skills in autism like language, but also to focus on more of the behavioral endpoint, like the aggression or social skills.
Okay. This next question is about anxiety. You just touched on it a little bit. So can you talk, I know you touched on it in the presentation, but maybe reiterate about interventions that are effective for people who have that diagnosed comorbid anxiety with these issues with self-regulation, where it's been identified and they're certain, they have that diagnosis. So is CBT a great therapy, or what are these other strategies?
I would definitely try it. CBT is considered evidence-based in autism, and it's mostly from these anxiety studies. Facing Your Fears, in particular, is a program developed for autism out of Colorado, and it's done as a group treatment, and is effective in reducing anxiety. That's developed by Judy Reven. She has some books available and a workbook and a therapist training manual. Jeff Wood also has an anxiety treatment for autism. So there are those structured manuals, and they are effective in treating anxiety for autism. So if that's the primary way that the difficulties are showing up, it would be worthwhile to give it a try, I think.
Okay. And related to that, although they're not referring to anxiety directly, they're talking about self-injury and self-biting, hair pulling, those sorts of things. So same thing here. They're asking that same question. They're asking about, in your research, what have you seen with those types of symptoms? Is there, with these strategies, do you typically see improvement in those, or do those need to be addressed in a different way?
I would say it's variable, and I don't think we have a great understanding yet of all of the reasons that self-injury occurs. So we have seen, like in our EASE open trial, for example, we definitely had kids who were self-injurious, or like a lot with pulling hair out or other, sometimes biting themselves. And there, when it did seem to be a behavior that was occurring when they were really distressed, emotionally dysregulated, we did see that decrease. I don't know that I can say that's the case across the board. I didn't discuss medications. I'm a psychologist, not my area of expertise, but there are medications that are approved for autism and irritability, and those have also been shown to be effective in some cases for SIB. But I don't think we have like a great understanding of why those are working and why everyone engages in SIB. But I mean, I personally, and it's maybe my bias, would be surprised if there's not some sort of underlying arousal or distress going along with it. We are looking at SIB as an outcome in that inpatient study I mentioned with arousal and physio. We just haven't had a chance to analyze that data yet, but we're hoping to figure out if we can see some early arousal differences before the SIB happens also. I'm not sure if that fully answers the question. We need a lot more research in that area.
Yeah, that's a difficult area. It's difficult for the people who experience it and for their caregivers, of course, and their
Yeah.
yeah. The next question is about medications as co-treatments. I know you're not a medical doctor. Has there been research on that combination of using behavioral intervention or CBT with or psychiatric drugs?
Not really. Well, there's been some. So there's been one study by the RUP group, which was a group that got together to do psychopharm medication trials, basically, and they did look at the combination of parent training and those antipsychotics that are approved for irritability, focused on irritability showing up as behavioral dysregulation. And aside from that, there hasn't been, that I know of, studies looking at the combination of medication and more traditional psychotherapy like CBT. However, I know that there are some announcements out there now for studies to look at that with anxiety in particular. So I do think that research will be happening in the very near future. There are no approved medications for anxiety or depression in autism, only those two that target irritability expressed as sort of dysregulative behavior.
Okay. And what about CBT in schools? Have you seen schools, are there different types of CBT strategies that schools are using? Has the EASE program been used in school settings?
Have a meeting in 2 weeks to talk to a school district here about that.
Okay.
Yeah, but we haven't started that yet. I would love to do that. I think, it's not a program that would be useful for everyone. It would be useful for someone who has struggles with emotion dysregulation. There is a lot more that's been done outside of autism in particular, with more universal programs doing like mindfulness with the program. Like one example is called Quiet Time. And they basically did like 10 minutes of mindfulness meditations in the morning and the afternoon in school districts, and found improvements in emotions, behavior, grades, number of suspensions. That's not an autism specific study, but I know there's movements to do those sorts of things in schools more widely. In terms of CBT, that is really, usually it's an individual therapy. It does require probably a school psychologist level training to do. I don't personally know of anyone doing it in the school setting, but it wouldn't surprise me if school psychologists were using those strategies in some cases. But it is usually, in terms of dosage, like an hour a week, minimum.
Okay, great. The last thing I'm going to ask you, we're almost out of time. People are asking, we have quite a few people on the call who are in your area, and they're asking about getting involved with research. So should they just reach out to you via email for more information?
That would be fantastic, yeah.